They've been dealing with this for years. Their mother dealt with this, their sisters deal with it.
But I have this thing I can give you and you're going to feel better. And I'm so excited that we figured it out. But from the patient experience, they hear you're just giving me a medication. Birth control can make you infertile. That's not true. I think it's hard for patients to understand that sometimes there's no fix. There's no cure, right? There's treatment, and treatment is different than a cure. And what happens to them the week before they get their period, and why they all of a sudden recognize, like, oh, I understand now why once a month I want to murder my partner.
All right, welcome back and thank you for joining us. I have a really special guest and good friend today with me. I have Dr. Fran Haydanik with us. Dr. Fran is a board certified OB-GYN and social media influencer based in Rochester, New York. She practices at Rochester Regional Health and is known for her accessible, evidence-based content on reproductive health, birth control, and women's wellness. You might know her online with over 750,000 followers across TikTok and Instagram. She uses her platform to empower patients with accurate medical information, which is much needed, and advocates for reproductive autonomy. Dr. Fran also created a widely shared list of doctors who perform sterilization procedures without requiring marriage or parenthood. So, doing a lot of great work, Dr. Fran. Thank you very much for joining me today. I want to welcome you to the show. It's great to have you.
Thank you so much for having what a kind welcome and intro. I'm so excited to be here.
Same here. Same here. And we talked a little bit offline about there's so much to cover, and you're doing a lot of interesting and great work, and you're a real advocate for the women's health community. And there's certainly an overlap with us in mental health. And the purpose of our show and our listeners is really to spread awareness and educate. But before we get to having a conversation about that, I'd love to share with our listeners a little bit about you and your background, how you started, and what are your goals with all the work you're doing in terms of spreading advocacy and education.
Sure. So, my story, especially on social media, started before I even went to medical school. Back in the early 2010s, everyone was taking pictures of their colored skinny jeans and big necklaces, and I said I should do this too. So I started a style blog, in the years before I went to medical school, and then I continued it on as I went through medical school, just sharing my experiences, what I was learning, and what I was wearing, because, as you know, you have to dress business casual for medical school. So I did that. Then, when I graduated from school and started my OB-GYN residency, I was working 80 plus hours a week and I wore hospital scrubs 100% of the time. And so, who's taking pictures of that? Not me. So, I basically fell off the face of the internet for 4 years and then came back out on the other side. At that point, I had had two children through in my residency. And then I took 6 months off after graduation so I could be home with my kids before starting my attending job and started scrolling on TikTok. And all I kept seeing was videos. And, the FYP, it learns who you are. And so my FYP learned that I was really interested in things like pregnancy and birth control. And so it kept feeding me these videos of incorrect things. And I was like, this isn't even right, but who's here to like correct it? So I was like, well, I should correct it. So I just started posting videos on TikTok, a lot of times correcting misunderstandings or, deliberate misinformation, and grew from there. In 2022, when the Dobbs decision was leaked, I started listening more and more to people saying, like, I don't want to have children, but I can't get sterilized because my doctor won't let me. And I had a group of people who I knew supported that. So I started a small list. At the time, it was 150 OB-GYNs who supported younger patients, adult patients who weren't married or didn't have children but wanted to be sterilized. And by chance posted it the day that the Dobbs decision was made final. That video went viral over and over and over again, and it's grown up to 3,000 gynecologists at this point. And I can't tell you how many countless people it's helped get really what their desired choices for their bodies. And my whole platform is that I want people to have a choice in all things when it comes to, OB-GYN, and that means getting sterilized if they want to get sterilized, having an elective induction if they want to have an elective induction, being on birth control or not being on birth control, as long as it's like they are making that choice themselves. I think the field of OB-GYN historically has not always been great about giving patients all of their choices and has taken a lot of that autonomy away from our patients. And I'm really hoping to have those continued discussions, not only with patients, but fellow healthcare workers, that we continue to really be open to what is our goal as physicians and healthcare providers, and that is our job is to give patients their options, make them know what the risk and benefits are, and then patients choose what's right for them, and we support them in that. So that's really my whole goal. My long-winded way of saying I just want patients to know their options and really feel empowered that they're making the right choices for themselves.
So not to go down a rabbit hole, but what have you been telling patients that are in states that are less favorable and more challenging, even if they have your list, what is it that they're supposed
Yeah.
to do?
Well, I mean, if they live in a state where, I mean, any state, I live in New York State, so we are very liberal and protected here. But for anyone who knows that they don't want to have children, I want them to have that resource of finding a doctor who will help them get sterilized. No matter what their other reproductive options are, if you don't want to get pregnant, then you don't have to.
So you're having patients travel outside their state, pay out of pocket if their insurance doesn't cover procedures. How do they overcome the challenges of living in a state where their hands are tied?
Well, so for sterilization, no one's hands are tied. That's the great thing. So to get your fallopian tubes removed, you can do that in any state currently. And our list does cover all 50 states. We have doctors in Hawaii, Alaska, New Mexico, everywhere. And all sorts of city sizes. So even people who live in more rural places usually can find a doctor within an hour of their location for someone who will sterilize them. So even if they don't have their abortion rights anymore, they currently still have the ability to get sterilized if that's what they want.
Awesome. No, and you're doing great work. The misinformation hit home. We see that as well in psychiatry, mental health. Everyone is an expert. We see it in fitness, in wellness. Everyone is just spreading a lot of information. Some of it is evidence-based, which is awesome, and some isn't. And how did you go about tackling that to make sure you're a credible source and you're not just trying to kind of enter that same dynamic where everyone is fighting for everyone's attention, but you're really leading with your credibility. How did you penetrate that?
I always think it's been very important that I lead with my doctor title, so I make it very clear of like who I am, and that is that I have a DO degree, I'm a board certified OB-GYN, and that itself gives it some credibility, right? That I'm not just Joe Schmo telling you about PMDD, but I'm actually a board certified physician who's telling you about it. And then almost for everything that I post about, will give references, put up-to-date algorithms on the screen, share ACOG practice bulletins, share studies or PubMed articles that because I really want people to feel that they can go read it. It's okay, it's nice to see me talking about this practice bulletin, but if you want to go read about it yourself or read the study yourself so you have a better understanding, that's the whole goal. And I think that's what differentiates a lot of physicians from the lay public is that not only can we give you the evidence that supports it, but we also understand it in a way that we can translate it to the public.
Yeah, interpret it.
Um, Pardon?
Yeah, interpret it.
Yeah, we're interpreting it for you, right? But also giving it to you that if you want to read it yourself, people are very smart. They know how to read. Many people are trained in understanding studies. So I want people to really have that resource to be able to educate themselves. I don't want to just spoon feed it to them if they don't want to be spoon fed. But if you just want a quick 60-second video and then you move on, I have that for you too.
That's awesome. Have you found that there's a particular topic or theory that's misrepresented often that drives you nuts that you keep having to correct?
I mean, a lot of it for me, of course, is around birth control misconceptions, right? So like birth control can make you infertile. That's not true. Birth
Oh, no,
control
no
causes
pun intended. Yeah.
PCOS. Right, exactly. Um, Birth control gives you PCOS. Birth control makes your partner not attracted, all these weird things. So a lot of birth control misunderstandings, and then a lot of misunderstandings about the labor and delivery process. I think, I love that people share their own experiences, but the lay public only has, a handful of personal experiences with pregnancy and laboring and delivery versus someone who's professionally trained in it and has thousands and thousands and thousands of hours and patient encounters to like have a whole picture of what pregnancy can look like, right? I myself have had 3 uncomplicated pregnancies and deliveries. That doesn't mean that everyone has uncomplicated pregnancies and deliveries. So if I were only share my own personal experiences, it would seem very like no big deal. But as an obstetrician, I've stood in the cath lab with a scalpel in my hand because that patient needed to be in the cath lab due to pregnancy complications, right? And the lay public doesn't participate in that. And so it's kind of my job to bridge that gap between the two.
Yeah, absolutely. And I think patients are yearning for more knowledge and they become more prepared to when they visit their physician. So being there as a resource is huge. In terms of mental health, what have you seen?
So one of my most viral videos I made actually was about PMDD. And I think I'm grateful that more and more people are understanding this connection between the menstrual cycle and what's going on with their mental health and what happens to them the week before they get their period and why they all of a sudden recognize, like, oh, I understand now why once a month I want to murder my partner. I didn't connect that before, but now I have. And then also realizing that that's not a normal experience. Just last week, I had a patient who's like, I just feel so terrible during that week. And we went through some of the criteria. And then I told her, I think you have PMDD. And she goes, so this isn't normal? I've just been told that this is normal. And I was like, this is not normal. Like, this is not the experience shared by most people. And let's figure out how we can help you with that. And so I think there's some misunderstanding. People don't want to talk about it. Historically, the public has not been nice to women, right? The words hysteria come from a place of not good. And so, same with like, oh, you're PMSing. Like, no, sometimes people can just have feelings that aren't related to their menstrual cycle, but sometimes they do have feelings related to their menstrual cycle, and those are valid too. And as a condition that we need to like not only recognize, but also give treatment options for.
So it's interesting, you're going down the PMDD route. I've had patients with PMDD who feel that as a psychiatrist, I'm quick to medicate. Uh,
Mm.
and they feel that if they go to their OB-GYN, they likely wouldn't get treatment. What would you tell patients who are skeptical about treating their PMDD because they feel that they've been dealing with this for years, their mother dealt with this, their sisters deal with it, it's just a way of life?
Yeah, I think, it's hard for us as physicians because we know that they've been dealing with it for so long. And then we say, but I have this thing I can give you and you're going to feel better. And I'm so excited that we figured it out. But from the patient experience, they hear, you're just giving me a medication and not fixing me, right? I think it's hard for patients to understand that sometimes there is no fix, there's no cure, right? There's treatment, and treatment is different than a cure. And I think that's a problem with sometimes on the internet that people make you feel that there's a root cause that we as physicians aren't curing, but we just understand that like the science is at the point where it can't be cured currently and we can manage. And so I think what is important for many of these conditions that I treat from like PMDD to PCOS to endometriosis is kind of having a really good understanding of all of the treatment options to give the patients so that they feel that they were given those choices. So for PMDD, we talk about like Vitex or Chasteberry, lower evidence, but some evidence supports it. And I've had patients who do feel better on it. So we talk about that. And then we talk about, like SSRIs, luteal phase versus consistent and giving them those options. Or we say, like, listen, this is happening because you're ovulating and your progesterone's increasing. And that is your like neurotransmitters are doing something crazy with it with the elevated progesterone. Not that your progesterone is higher, but that your brain is receiving it in a different way. And so we could also stop the ovulation with something like a birth control and playing around with those different supplements, lifestyle changes, SSRIs, birth control options. I think that's where we in the field have kind of disappointed our patients is that we aren't giving them kind of like all of those options because we know that the SSRIs are going to work. We know that people are going to feel better, right? But patients want to have the options. And so I think it's really important in any medical field in any situation that we're kind of continually learning, continuing to know what's out there, being able to translate that to patients saying, hey, we do have this supplement. Some patients feel better on it. And if you want to start in a less medicated place, that's a good place. But if you're in a really bad place right now and you need to feel better today, then that may not be your option.
Yeah, I think what you're hitting on is the transition from what used to be the omniscient, omnipotent, kind of paternalistic
Yes.
doctor who dictates what you should do versus educating and empowering the patient to make the decision for themselves. Unfortunately, with reimbursement, you don't always have the time to do that. Even if you know as a physician that is the best thing to do for the patient, uh,
Yeah.
when you work for a hospital system and you need to see X number of patients a day and you got to go to your next patient, it conditions you for the worse to just diagnose, treat, and you actually become a worse doctor because the system is pushing you in that direction, where I don't even have time to explain to you the side effects. We got to keep going here. Just trust me, this is the best thing for you. And it's like you're saying, it's doing patients a huge disservice
Yeah.
because
And I think patients have to understand that we could have you come back and I give you the dedicated time for a consult for PMDD. Unfortunately, that comes with the cost of you have to come back here, but then you get the time. You get
yeah,
my time. This isn't an annual exam where we're doing your pap smear and ordering your mammogram and talking about your grandma's breast cancer. This is just an appointment that, yes, you have
yes.
to come back for, and yes, you will have to pay for, but you will get better care.
No, absolutely. And I think we need to encourage patients to demand that because they really need it. Where are you seeing gaps in terms of mental health in women's health?
I would say real pregnancy related mental health. I think everyone knows about postpartum depression, right? We all know that that's a thing, postpartum blues. But the bigger things out, postpartum anxiety, postpartum psychosis, obsessive compulsive disorders that come out in that postpartum period, the intrusive thoughts that come during that time. But also in pregnancy, managing mental health conditions is really hard. And we talked about this, that bridging that gap between psychiatry and obstetrics. And we need more like reproductive psychiatrists who really have a really deep understanding of both sides of medicine and can merge it together. A lot of times, as an obstetrician, I'm not fully trained to handle those more complex psychiatric conditions, and I do the best that I can, but is that the best for the patient? And there aren't enough psychiatrists to be able to help me either. And so that's where the gap I think really falls right now is in pregnancy related mental health.
Yeah, I would agree. I think particularly postpartum, there's a lot there. Bipolar in pregnancy is complicated to manage, and a lot of times OBs try to manage it, and it's difficult. Psychiatrists, especially in areas that are more rural and there's less access to care, it's tricky. So certainly think there's room for improvement there. With telehealth, we have done a little bit better. We can get a psychiatrist involved with a case. We don't have to see them face to face. So headed in the right direction, but certainly a challenge. With all of your content, have you found that patients are gravitating towards a specific topic or an issue or an area where they feel there was a gap? I know what you're aiming to deliver in terms of information and content, but in terms of what's being received, have you found that patients are gravitating towards something specific, or were you able to identify any patterns in terms of engagement, comments, questions? Is there a gap there in terms of uh, patients were yearning for something they weren't getting elsewhere?
I can't think of like a specific thing really related to that question. I think what patients online especially are really yearning to do is to share their experiences, especially when they're negative experiences with the medical system. And as hard it is at times to hear that as a physician, because we're really trying the best that we can with what we have, both from like medical understanding in general to limitations of working in a healthcare system to taking care of more and more patients when there's less and less of us. But I do think it's important that we hear our patients when it comes to that. So, for example, within the field of gynecology, we have not done a good job of managing pain during an IUD placement. And it really took patients online saying, this was my terrible experience having an IUD placed. And like, we deserve better, that it really took that to have the whole field of gynecology say, wow, actually, you're so right. We haven't been guiding our physicians the right way. And now we have guidelines for that. So I think what most patients really are most yearning for is to be heard. And then to have something come out of that.
Yeah, I mean, I felt that too. Particularly, I think patients are not as critical as people think if they are brought along for the ride and the journey and they're with you there along the way. Um, I think there's a misconception that patients could be very judgmental, very critical, You only get one chance at getting the right answer. You can't make a mistake. We live in a very litigious society. But I've noticed if you're very forthcoming, very apologetic if there is a mistake, um, that you express your limitations. I don't know. I'll look it up. I'll get
Yes.
back to you. Patients are really
Yeah.
appreciative that you're honest, you're forthcoming, and you're a partner in the process.
Yes.
Um, would love to see more of that partnership between women's health and mental health as well. A lot of
Yeah.
times, I think psychiatrists, mental health practitioners are intimidated to contact an OB-GYN, and sometimes OB-GYNs are very busy and feel like that's just another layer that they have to overcome to now incorporate into treating a patient holistically. Now I have to also figure out their mental health issues. It's complicated, right? There's a little bit of a spider web that you have to navigate. So certainly see that, and I would encourage patients to be partners with their physician, and then medical professionals, healthcare professionals to also be partners with their patient to really make sure that the outcomes are as favorable as possible.
And I think it's really hard as a physician to say, I don't know. But last week I had to tell a patient, I was like, I don't know what's going on with you, but I think you need to see this person who's had extra training and like knows more than I do. And I wish I could be that person for you, but I have to recognize my own limitations for your benefit. And I told her, I was like, I could muddle around here for a while longer and waste your time and money, but I don't think I'm the right person for you. And I think it's really important to be able to say that to your patients because you can't, and I say this to my trainees all the time, that it feels like an OB-GYN has to be everything for everyone, and that's not always possible. And you have to rely on other people to be able to maybe be better than you in certain things. And so, like, I recognize my own limitations surgically quite a bit. And so I'll tell my patients all the time, like, I'm not the right person for your endometriosis, but my friend who's my partner and I share an office with is, and she'll take great care of you. And I might be the right person for your PCOS, but I'm not going to be the right person to figure out why you haven't had a period in 6 months, but everything that I can do is normal. And so, for all healthcare workers, being able to say, I don't know, is one of the best things you can do for your patients.
Absolutely. Taking it in a different direction, we also deal a lot with body image issues, body dysmorphia, eating disorders. How have you felt the overlap has been between mental health for body image issues and eating disorders has been supported by deal as an OB-GYN?
Well, it's hard for us because our patients are going through major physical changes in a short amount of time. And so, for patients who already struggle with some of that, with the control over their bodies and or lack of control, then going into something like pregnancy where all of a sudden you don't have control and probably are suffering from things like nausea and throwing up and extreme fatigue and all of those things. It's really hard. It's really hard for those patients to go through that experience and for me as their physician to support them through that. I think for me, I really don't focus a lot on my patient's weight. I couldn't tell you the last time I said to someone like, "Hey, you've gained 7 pounds," right? Like we give them guidelines at the beginning of pregnancy. That's evidence-based. That's, from ACOG. Hey, your BMI is 24, so we do recommend that you gain 25 to 35 pounds. But after that, like I'm not going to sit there and hound you. And I um, could only imagine that that would lead to worse patient-physician relationships. So it's hard. It is definitely hard for those patients to go through that experience.
Absolutely. No, we're out of time, and I think we could talk forever. One thing I would be curious to understand, the system often separates mental health from physical health. What advice would you give our listeners who are dealing with issues with their physical health and their mental health and having a hard time navigating the system?
I mean, that's so difficult because there's not one answer that's going to be the right person, like the right thing for everyone. I think finding a team of people behind you who can guide you through that, whether that's like a primary care doctor who knows you as a full person and can guide you to the right people, whether that you have a therapist who is your person for talking through and learning those coping mechanisms with, while at the same time having a psychiatrist who knows how to help you on the medical side. It's hard to build the team, but I think it's worth it. And that might take a couple of different second, third opinions to find a new person for you. But there are very well trained and thoughtful people out there who want to help you. It just is a matter of, unfortunately, finding them and corralling them behind you.
Absolutely. I think a strong treatment team is the right answer, and there are skilled professionals across the board. Certainly wouldn't neglect one to treat the other. So I
Exactly.
would prioritize um, holistically your entire well-being, and I think that makes a big difference. Dr. Fran, I really appreciate you joining us today, full of wisdom and insight. You're doing excellent work, so I salute you for that. Wish you a lot of luck on that journey. Of course, you're welcome back on our show anytime, but thank you very much for being here today.
Thank you so much for having me.